All right, let's go over some definitions. So, most importantly, when I'm talking about intraoperative awareness, I'm talking about memories that are formed in the operating room of sensory perceptions and that are then subsequently recalled after the surgery. I'm not referring to episodes of awareness in the operating room which are not subsequently remembered. So it's a very specific definition for this talk. I freely acknowledge, and I think it's important to remember this, that many patients probably have episodes of intraoperative awareness that are brief or even more prolonged, but that they don't seem to remember after their surgery. And all of the evidence that we have, for obvious reasons, can only be for episodes that people remember afterwards. Otherwise, it's hard for them to report that they were aware. There is some literature about intraoperative awareness without recall, where patients have followed commands during surgery, but the relevance of that in terms of the long-term consequences to patients is unclear, and philosophically there's a lot of debate about whether or not that's acceptable. For my own part, I would rather not have awareness during surgery, even if it were not something that I remembered afterwards. But going back to the definition that we're dealing with, or that I'm dealing with in this talk, and that's awareness with recall. And the way that can be classified is according to the Michigan Awareness Classification Instrument that classifies intraoperative awareness from no awareness through only auditory perceptions, going all the way to experiencing pain and paralysis with a feeling of distress associated with it. So intraoperative awareness can range from just an isolated perception to a much more severe experience, and any of these experiences may or may not be associated with distress. This is a busy table of definitions, but it's actually well worth looking up if you have the leisure, and I encourage you to do that. It's in the New England Journal of Medicine, an article published by Campagna and others from Boston, and it defines some key terms. And the terms to which I'd like to draw your attention are amnesia, which is the partial or complete loss of memory, and certainly that's one of the aims of general anesthesia, to achieve amnesia. I believe that another aim of general anesthesia is to achieve unawareness, but as I referred to earlier, there is some controversy around that. Some practitioners believe that it is acceptable if a patient has awareness as long as they don't have memory. My bias is that they should neither have awareness nor memory. MAC, or the median or minimum alveolar concentration, is the amount of volatile anesthetic or concentration of volatile anesthetic required to prevent 50% of patients from moving in response to a noxious or surgical stimulus. And I'm not going to go through the other definitions now. I've referred a little bit to implicit and explicit memory. I guess that it's worth mentioning that one could have awareness with implicit memory, so that there would be some impact on the brain, but without us remembering it subsequently explicitly. And awareness with recall, the type of intraoperative awareness to which I'm referring, is explicit memory, where a patient has intraoperative awareness of sensory perceptions, like they feel the cut of the scalpel going through their sternum, and then they subsequently remember it and they tell you about it. This is a graph with a log of anesthetic concentration on the x-axis and the y-axis showing proportion of patients with a response. And what this graph indicates is that, generally speaking, the majority of patients need a much lower concentration of anesthesia to prevent explicit memory and perceptive awareness, even without explicit memory, than they do to prevent movement, and certainly than they do to prevent an autonomic response like hypertension or tachycardia. So that if you give enough volatile anesthetic, for example, that you would prevent movement, it is extremely likely that you would also prevent perceptive awareness and awareness with subsequent explicit recall. However, unfortunately, although these curves are steep, and it's generally speaking true for the vast majority of the population, that if you give a particularly high dose, you would almost be guaranteed of unawareness, there might be some exceptions of people who are relatively resistant to the hypnotic effects of general anesthetics, and unfortunately we don't know specifically who those people are. It is thought that you need some time for memory consolidation, and this is thought to be about 30 seconds, which means that if a patient has awareness in the operating room, if it were very brief, it might be unlikely that they would consolidate memory and then remember it subsequently. In thinking about that previous graph where I showed a log dose response curve, there are things that are known to increase and to decrease the amount of volatile anesthetic that we require to prevent movement to a noxious stimulus. And in the big arrow at the top are factors which are known to decrease the amount of anesthetic required to abolish movement in response to a noxious stimulus. And more important to remember are the factors that require increased anesthetic in order to abolish movement in response to a noxious stimulus. Because those are the factors that if you don't take them into consideration, you could potentially underdose your patient. So know about things like hypothermia, younger people, people using amphetamines, cocaine, if you are using ephedrine during your case, or if a chronic alcohol user, those are examples of people where more anesthesia would be required than usual to achieve a therapeutic endpoint. This graph shows the age effect on the amount of anesthetic required, and these are ISO-MAP lines for people going from the age of 0 to 100, and in this case it's for the age of desflurane. These curves were made by Nichols and Mapleson and were published in the British Journal of Anesthesia. So you can see, for example, the ISO-MAC line for 1 MAC. So for 1 MAC, when you're 10 years old, you need about 8% or 8 kilopascals of desflurane for 50% of people not to have a response to a noxious stimulus, whereas for an 80-year-old, you'll need only about 5 kilopascals or 5% desflurane, so almost half the concentration of a much younger person. Neural inertia is a concept that was described by Max Keltz at the University of Pennsylvania. Max is a dear friend of mine. Hi Max, if you watching this, I hope you won't contradict my statement. And Max was referring to the fact that the brain resists state changes. So just like ice resists state change from going from its frozen state to water, you need to put in, there's a latent energy required for that. So similarly for the brain, when it's awake to fall asleep, or when you're asleep to wake up, or when you're anesthetized to become aroused, or when you're aroused to become anesthetized, there is inertia, there's an inertial barrier which we have to go across in order to make that shift in phase. And it is possible that that inertia is relevant for humans. It certainly is in animals, and Max and his colleagues have done this work in fruit flies and in mice, where they've shown that the induction path and the emergence path have a hysteresis between them, so that you actually require more anesthetic generally to induce anesthesia than the concentration at which responsiveness is restored. The usefulness of that from a clinician's perspective, if you stop and think about it, that's actually really helpful, because that means that we have a safety barrier, that if you give sufficient amount of anesthesia to ensure that somebody has loss of responsiveness, then you usually would need less than that for them to become responsive again, because of that inertial barrier in the opposite direction and the hysteresis. However, it is possible both in animals and potentially in humans that you could have collapse of that hysteresis. And if there are some humans where that hysteresis collapses, that you actually become anesthetized and become aroused at concentrations of anesthetic that are very similar to each other, that would eliminate a bit of that safety margin or that cushion of safety that we have.